So I'm going to talk about a controversial subject, refractive surgery in the setting of a patient with keratoconus or keratoectasia, like post-LASIK ectasia. Same disclosures. Relevant ones would be RxSight, Star Surgical, because I will talk about LALs and ICLs. So today I'm going to just do a quick review of keratoconus and indications for cross-linking in case you are not someone who takes care of keratoconus patients regularly like I do. I take care of so many. I'll talk about 3 techniques to help these patients who are oftentimes young with regards to getting them less dependent or not dependent on glasses or contacts, and then just final tips and takeaways. So keratoconus or keratoectasia. Keratoectasia is the most broad term, which includes keratoconus, also includes pellucid marginal degeneration, includes post-corneal refractive surgery ectasia, like post-LASIK ectasia. It's progressive, it's non-inflammatory, characterized by localized thinning, usually centrally and inferior in the cornea, and it gives you that cone-shaped deformation. This is a pretty intense photo of this, Munson sign. If they look down, it kind of pushes out the lower lid. And then on topography, you see this inferior steepening here. It's classic. Frankly, not even that severe keratoconus in this topography. And it leads to irregular astigmatism, myopia, because the Ks get higher and higher. And it's difficult to correct these patients after a while with spectacles and finally with contact lenses. They cannot oftentimes tolerate if it becomes more and more severe because the contacts don't fit well on top of their eye. And so then these patients will go into scleral lenses, which on their own have their challenges. Some people love them, but most people hate them. They make people's eyes red and just over, if you wear them for hours and hours every day, you can get very irritated and red eyes. And it's keratoconus is bilateral most often, oftentimes asymmetric. Everybody asks about rubbing, and that can be an association, but I find that if I ask my patient, what is your sleeping position? Many of my keratoconics, they sleep on their stomachs. And when you sleep on your stomach, you have to choose a side of your face to sleep on. And I'll say, show me, show me how you sleep. And they'll go right to it. They'll go like this. And then the right eye is like blown out keratoconus because, for years and years, they've been sleeping on that side of their face. And I feel like I didn't learn that in the books, right? But you just find that there's a lot of association with stomach sleeping and sleeping on their side, or someone who is not a stomach sleeper, but a side sleeper who really favors one side, maybe because of a shoulder injury that they had a long time ago or something like that. You'll see asymmetry because of that. These are the clinical findings. We're all aware of these. And so indications for cross-linking, I do probably somewhere around 2 to 4 cross-linking a week. I have a great team that helps support that. I, frankly, will do the debridement in between my cataract cases, and then my team will do the dropping and the actual light treatment, and I come in between cases and monitor. I'll go back in, and then I'll place the final bandage contact lens at the end and take a look at my patient behind the slit lamp. But basically, if a patient has progressive keratoconus, you're following them every 6 months, and you're seeing their manifest worsen and change. You'll see their topography change where their Ks are getting higher and higher. Sometimes you just start to realize that they're complaining that their vision is changing. That alone, you can tell it's progressing. But officially, you have to, for insurance coverage, which many people are trying to use their insurance because otherwise cash prices are in the many, many thousands of dollars because there's a monopoly on cross-linking. It's Glaukos, and they're the only providers of FDA-approved cross-linking currently in the US. And just to purchase a kit for a patient, it's almost $5,000 now. No joke. So a lot of people, understandably want to do this through their medical insurance. So you need to see an increase in Kmax of a diopter increase in corneal thinning. These are all, you can see these with topography, and increase in MRX, spherical equivalent, or cylinder of greater than 1 diopter. It doesn't have to be all of these. You just have to see at least one of these. And with younger patients, teenagers as an example, when their Ks are really, really steep, this really predicts rapid progression. That's who progresses. And so you don't actually even have to show much change with these young patients. You can get coverage for these young men usually who have Ks in the 50s already. It's like you better start cross-linking them. It's ideal to have corneal thickness greater than equal to 400 micron throughout, though oftentimes, we've done thinner, and you can argue for that, but it's safe. It's at a safe level if it's at least 400 microns. Oftentimes it's in the 300s. Okay, so what do you say to your keratoconus patient, which is the topic of this talk, when she is like, okay, great, you're gonna stabilize me. That sounds great, but when are you gonna make my vision better? That's what your patients want. They understand, they're young first of all, but they just want better vision, and they have glasses that are this thick, and they can't tolerate contacts or sclerals oftentimes, and they just wanna know, how can you get me seeing better? And a lot of times we as physicians will get this stern face and say, what are you talking about? Like, you have this real disease. Like, you're lucky to be seeing, and we get into this serious mode, and then they're just gonna shut you out. Because if you're not empathetic to what they are going through, they don't want you as a provider. They want to hear you say, hey, let's make sure that we stabilize this so it doesn't get worse. Let's stop it in its tracks as much as we can. Let's let everything heal. Let's make things so they're not getting worse. And then at that point, we will, I promise you, let's think about the ways that we can help you see better. And perhaps that would be, maybe, without contacts or glasses. Can't promise you anything, but maybe we can reduce your astigmatism with certain ways. Get on board with them, get aligned with them so that they feel that you understand, truly what is bothering them, which is the fact that they have these crazy glasses and scleral lenses that are very uncomfortable. So one way, so all of these are suggested ways to correct vision, to get patients less dependent on contacts and glasses in stable keratoconics. So that usually means they've been cross-linked, or maybe you followed the patients for enough time that you know they're stable and they're ready to do something. So one is phakic IOL surgery with EVO ICL. I can go through this quickly, but basically most keratoconic patients, they're younger, they're pre-presbyopic, and so you want to do a surgery that's going to retain their natural accommodation. So why not just put in a lens that can help correct some astigmatism up to 4 diopters and treat high myopia, which most of these patients have, and then they still can see far and up close. And many of them are, require the toric form. And I tell my patients generally, keratoconus is very difficult, to treat all of the prescription perfectly. That their vision is often going to be better with a scleral contact lens, but we can debulk their prescription so that their glasses are not so difficult to wear. So they might have a much lower myopia astigmatism correction, which they don't mind wearing. These patients are very, very reasonable. But instead of wearing the thick, heavy glasses, they could wear a lighter, more reasonable pair and not be blind without their glasses. So you can debulk a lot of their prescription with an ICL. And so I always tell my patients that have keratoconus and have ICL surgery, expect to have post-surgical glasses to see at your best. Interestingly, many of them, we prescribe them and they don't wear them because they feel like their vision is really, really good compared to what it used to be. But if you set up that expectation, then they're not disappointed when we say, okay, let's get your prescription for glasses going. Corneal refractive surgery, as we all know, is not recommended and should not be an expectation of these patients. Although I will talk about a subset of keratoconics that you may consider PRK in the future if you ever want to try it. I don't even do it myself. It's a friend of mine who does it routinely. And also, finally, these are myopes, and so there's a lot of assumption that keratoconics are just like high myopes, and they're going to have large anterior chambers that you're going to be able to place in ICL. But some of these patients, have very small anterior chambers, and so you have to do the measurements to make sure that an ICL is a good idea and a safe idea for them. So you would just treat these like any ICL workup to make sure their anterior chamber measurements are safe. So at least 3.0 depth from the interior, the endothelial layer of the cornea down to the anterior capsule, and then the white to white measurements we talked about, somewhere around 11 to 13. The next type of refractive surgery you could consider is refractive lens exchange, and you would consider refractive lens exchange in a patient if the patient is already presbyopic, just like that's who you consider RLE in any way these days. The patient has already lost their accommodation. They know what it's like to struggle without their natural accommodation. There's something about taking away accommodation that makes patients feel horribly cheated and lied to. So if you can do this in a patient who has already lost it, then they get it. They understand when you're trying to bring back ability to see up close in a more artificial way, they're grateful for it and they're not upset with you. And then consider RLE, even in a young patient. Consider it if the anterior chamber is too small to house an ICL. So maybe they have an aqueous depth of 2.4 and kind of a micro anterior segment, even though they're highly myopic, as an example. That happens sometimes. You don't want to put an ICL in that patient. And then also, sometimes patients have early lens changes, so they don't have a full-on cataract. You don't want to put an ICL in a patient already with a cataract. That's kind of a no-no. So if this person is incredibly motivated, they can't tolerate sclerals, their glasses are ridiculous and heavy, maybe you want to do an RLE in this patient. The different types of intraocular lenses, and this is kind of a little bit in the order of my preference, and this is, remember, these are patients who they don't have cataracts yet. They want vision correction. So I don't even really debulk with a standard because I know it's not going to get enough of their astigmatism. So I will usually go pretty quickly to a light adjustable lens. Light adjustable lenses work really well in these stable keratoconics because the diopter, the lowest diopter of an LAL is a 4 diopters, so it's a little bit lower than some of the lenses we're used to. Some of them are 6, some are 5, so this goes down to 4. LAL plus goes down to -2 diopter actually, but we don't want to use an LAL plus in a keratoconic because that's too much higher order aberration potential, bad vision quality, so I stick with LAL normal. And so the beauty of the LAL is even if you put in an LAL and they're going to end at a -2, which is too myopic for their happiness, you're going to be able to adjust it with the light treatments to plano or whatever your plan is and hit at least 2 diopters of astigmatism as well, if not more. I've squeaked out 4 in my keratoconics, but it's FDA approved for 2 diopters of astigmatism. You can also debulk keratoconus patients of their myopia and astigmatism if you don't do light adjustable lenses with a toric lens. It's not ideal because it's really hard to predict how their vision will be corrected with a toric because their astigmatism is so irregular, but it certainly will debulk. And these are the patients where you're like, we can't adjust afterward and we're not going to do LASIK afterwards or PRK, but it's going to make it so your glasses are less thick and intense. And patients, I've had very happy patients who didn't want to go through the light adjustable lens journey, didn't have the time, or frankly, the T9 toric could correct way more than an LAL could. So sometimes we went that direction just to get as much astigmatism as possible. So toric. I talked about the standard. Definitely possible to debulk myopia, but you're not going to touch their astigmatism. And finally, this is something I learned pretty recently. I haven't done it, I'll admit, but it's stacking lenses at the same time inside the capsular bag. So you put in a toric, like a T9, to get as much astigmatism as you can, and then you stack an LAL on top. And so you can do the math and split up, how much of the power you want to put in the LAL and how much you want to put into the toric, but you'll definitely go T9 for the toric to get all the sil, and then stack an LAL on top. Let them heal. You've got an acrylic and a silicone lens, and then you do their light treatments to capture, maybe the additional 2 or 3 diopters of astigmatism and whatever myopia was left over. So this is something that I learned at a recent ACOS meeting by doing a simultaneous stack of 2 lenses in order to hit as much astigmatism and myopia as possible. So I'm going to be excited to try this. I've had patients where the astigmatism was like 7 or something, and a toric's not going to get it all, and neither is an LAL. So I'm going to stack them. I'm going to suggest stacking them. And then finally, we all know, avoid multifocal, avoid EDOF, which includes LAL+. These are not the patients to be doing that kind of lens in. They're going to have horrible quality of their vision, even if you are able to correct their astigmatism. Absolutely stay away from those. So I think we covered this. LALs are great because they're monofocal, good quality vision. They come in low diopters, and just that customization of their astigmatism. You're figuring out what manifest helps them see their best, and then custom shaping the lens to help, basically, put the prescription inside the lens, inside the eye. And it's interesting, you think you're not going to be able to give them great vision because they have 5 diopters of astigmatism, but you would be surprised when you have that internal lens correcting the majority of that astigmatism, how well these patients will see. The final way that I have not used, but a friend of mine uses routinely, Dr. Mark Lobanoff, is topography-guided PRK with immediate sequential cross-linking. So doing the PRK, and then 1 day later, so that they're separated by 24 hours, even though one of the PRK is not under insurance. Insurance doesn't like multiple procedures in 1 day. They might reject your cross-linking claim. So do just 1 day apart PRK first. You've done the treatment on, I'll explain, on flattening a cone, for instance, and maybe some spherical equivalent correction. And then doing immediate cross-linking the next day to strengthen the cornea so that ectasia doesn't occur, further ectasia doesn't occur. If you do cross-linking first, and let's say wait even a year or 2, you've got those strong fibers strengthening the cornea, and then you thin and shave the cornea with PRK treatment, you're reducing the cross-linking strength, and you could then have resultant ectasia. So it makes more sense to do PRK first and then to do the cross-linking immediately after to strengthen the cornea. So these are patients who have not had cross-linking yet most of the time. They have mild keratoconus. They're not severe or even moderate patients. And this is called the Minneapolis Protocol for the treatment of keratoconus. And I'll give all the credit to Dr. Mark Lobanoff. He is the person who, if you guys do LASIK, he is the person who created the 4 cities treatment that hooks onto Contura, LASIK, the Wavelight Suite, LASIK, excimer laser. You can use something called Contura as your treatment plan, and 4 cities he's super brilliant, is a way to sort of make sense of your Contura planning. So I give him credit for that. But this is basically, as opposed to cross-linking followed by PRK, it's PRK first with immediate cross-linking. You only have to remove the epithelium once as opposed to twice in the upper, sort of more traditional way to do it. And we talked about how this allows the cross-linking to actually have its full effect. So basically, we use Contura, which is a program that is connected to the excimer laser that Alcon produces, with Forcities, which is another program that hooks on to help you make clinical, it's a clinical decision support software. And basically, we're trying to correct as much sphere and cylinder as possible, but usually it's not all of it that the patient has. You're just as much as you can do safely. It will the program will remove anywhere from 50 to 150 microns of corneal tissue, and then immediate cross-linking is 24 hours later. And Dr. Lobanoff uses his own device that's kind of in the works of FDA approval, but he calls it the C2 device. And it's a cone shape, it's a little cone that suctions right around the limbus on the cornea, and it floods the cornea with riboflavin. Instead of dropping it on, it floods this container, this closed container, with riboflavin. And for about 5 minutes, it's pressurized, and that it will soak the riboflavin into the stroma of the cornea. It usually takes more like 30 minutes, 45 minutes to soak in. So this happens in 5 minutes. Then it'll suck the riboflavin out of the chamber and then expose the cornea to 100% O2 while the UV light treatment is occurring, which takes about 10 minutes. So the entire process, instead of taking an hour and a half, is done in about 15 minutes. And so he has a series of, I think it's like 50 patients now, and 100% of his patients have improved best corrected visual acuity, and 30% of those patients have 20/20 or better binocular uncorrected visual acuity. And at 4 years, I think he has about 30 patients who have made it to 4 years, still with no progression in their keratoconus. So this is, more and more data is being collected daily. And again, I don't perform this, but I'm very interested to be able to perform this once the C2 device is available and once I see more data from Dr. Lobanoff. So in summary, with my 2 minutes to go, once you have a patient with keratoconus and they have been cross-linked and you have proven stability, and I typically wait about a year to look for that stability, and I tell that to my patient. I'm like, this is gonna be a long journey together and we are not rushing it. Then we can offer potentially EVO, toric ICL, sometimes spherical, but rarely. Mostly it's toric. If they're pre-presbyopic without any lenticular crystalline lens changes. You could offer refractive lens exchange with LAL, toric, standard monofocal if you want, stacking lenses if they're presbyopic or already have cataract or lens changes, and then finally immediate sequential topo-guided PRK with cross-linking if the keratoconus is mild, if the patient is pre-presbyopic. And I thank you for your attention.
Any questions?
Thank you. That was a great talk.
Thanks.
I was wondering if you have an older patient with keratoconus with a lot of cylinder, like 7 or 8 diopters, and you fully correct them, like with stacking the lenses, are they able to neuroadapt to having no cylinder?
Yes, they love it.
Great, thanks.
But you could confirm it with scleral lens, just diagnostic scleral lens, just to confirm. But they tend to love it.
Very thought-provoking, thank you. I wanted to ask about your thoughts on repeating the cross-linking, and if so, what are your indications? And secondly, do you use Intacs when you do the cross-linking?
So it's not common, thankfully, to have to repeat. I cannot think of any of my cross-linking patients that have needed repeating. I have taken care of patients that needed to have repeat cross-linking, that had their original cross-linking with a unit called Peschke, which I've never used it, but I'm not exactly sure what the difference was in the protocol, but I've had a couple patients that I've had to cross-link with the glaucose unit, the Avedro unit, and they're so far doing fine. And it's really the same indications. You see that their manifest and their Ks are changing again. And the good news is when I consent my patients for cross-linking, I do tell them there's a chance that you might need to have cross-linking again in the future because we're always going to follow you. So for those patients that I did have to treat again, none of them were surprised. They were kind of like, oh, I remember hearing that I might need this again. So that was a pretty easy patient to deal with. I don't use Intacs and never have. There's CTAC, which is similar, but it's instead of the hard plastic segment, it's a more organic, soft. I can't remember what the material is. Does anyone remember what the CTAC material is? It's cornea, right? Okay, that would make sense. It's processed cornea. So I am in the midst of becoming certified on that. But yeah, I don't use Intex. I have done refractive lens exchange on a patient. No, I'm sorry, it was cataract surgery on a patient with CTACs, post-cross-linking, post-CTAC. I did the cross-linking after the CTAC. CTAC was a long time ago. He had PSC cataracts. He was 2400 best corrected, even with sclerals, because his PSC was horrible. He's the one that I did LALs in, and he wanted bilateral distance. And he had something like 4 diopters in both eyes with his with his Intacs, and he's 20/20, doing really, really well. So we squeaked out a lot of SIL from him. Yes.
At what age do you stop cross-linking keratoconus? Because I feel like different cornea specialists tell me different things about they're too old to progress at this point.
Well, I guess no age limit. If they're progressing, then yeah.
If maybe you haven't followed them long enough to know if they're progressing, but they have significant topo changes, and it's someone that you're trying to do cataract surgery on.
Yeah.
Do you need to send those people for cross-linking first, or what's your thinking there?
That's what I would do. I would cross-link them first. If you have some data, sometimes you can get old records. Manifest and topo is most effective, and you can prove to yourself over 5 years usually that they're progressing. It's just maybe slower. And so, yeah, I definitely would cross-link them first, and it tells them that they have to, hopefully, if their cataracts are not that bad, they need to pause for 6 months to a year, and then you can either do standard surgery or something refractive.
More questions? Thank you.
Thank you
so much.
Thank you so much for having me.
Yeah.